I'm Dr. Rachana Prabhu and I'm a professor in the Department of Oral Medicine and Radiology, Yenepoya Dental College, and I'm here to speak on neuromuscular diseases. So, these are the contents of my presentation. Now, let us begin by understanding the concept of neuromuscular diseases. Neuromuscular diseases, it's actually a broad term which is used to describe various disorders of muscles, the nerve muscles junction, you can see a neuromuscular junction, and the peripheral nerves. Okay, so they are the neuromuscular diseases are basically the pathological conditions which originate either in the musculoskeletal system, the nervous system, or the interface between the two. Now, what is the significance of these disorders for us, that is the oral physicians? First of all, the prevalence of these diseases. The prevalence of these diseases is approximately 3 to 5%. So, oral physicians are likely to encounter these patients who have either had or currently they are having a neuromuscular disorders. So, secondly, the clinical relevance. Most of these neuromuscular disorders will have or they will present with some oral signs and symptoms, or the complications of these disorders could be there. So, that can affect the diagnosis, our treatment planning, and the outcomes of the dental management. Thirdly, the impact of these oral neuromuscular disorders on the oral health, right? So, these neuromuscular diseases may impair certain functions in the orofacial regions like chewing, swallowing, salivary flow, or oral hygiene maintenance, because of which these patients will be on higher risk for developing dental caries or the periodontal diseases. And the lastly and the most important is the challenges which we are going to face in managing these patients, right? So, maybe because of the physical limitations or because of the medical interactions. So, these patients will be on a long-term medication, certain medication. So, because of which there could be interactions of the medications with the ones which we are going to prescribe. Thirdly, because of the neuromuscular dysfunction, there are high chances of risk of aspirations or poor muscular control or altered healing response, right? As I earlier said, this is actually a broad term. It includes many disorders, but in this class we are going to discuss the most common neuromuscular diseases, particularly those which have a greater impact on the orofacial region and the dental treatment. Okay. Now, each topic I will be discussing under these following headings. Like for example, the etiopathogenesis. It's very important to understand the clinical manifestations if the etiopathogenesis is clearly understood. Following which we are going to discuss about the diagnosis and the treatment which is given for these diseases. And lastly, we are going to stress more on the oral health considerations and the dental management. Now, let us start with the first disease, that is cerebrovascular disease. So, by definition, cerebrovascular disease or the disorders are the ones which cause damage to the cerebral blood vessels, leading to impaired cerebral circulation. Now, there could be three events in CVA. The first one is transient ischemic attack, which is also called as a mini stroke. This is a reversible and which resolves within 24 hours. Secondly, there is something called as a reversible ischemic neurological deficit. As the name suggests, this is also reversible, caused because of the focal neurological deficits. It may last for more than 24 hours, right? And it is caused because of the localized cerebral ischemia. And the third one includes the stroke, which has progressive worsening of the symptoms over a period of time. Now, what is the etiopathogenesis of this? Here, there is impaired cerebral blood flow, which leads to ischemia or energy failure. And always remember, even if there is decrease in the 50% of the blood flow for 3 to 4 minutes, it leads to irreversible brain injury, right? So, following ischemia, what happens is there is cerebral infarction, leading to edema, and ultimately it results in tissue injury and cell death. Okay, so this is the pathogenesis of cerebrovascular accidents. Now, what are the types of strokes? There could be two types of strokes which can happen. One is hemorrhagic strokes, wherein there is bleeding inside the brain, and the second one is the ischemia, okay, because of ischemia. Now, hemorrhagic stroke, the most important risk factor here is hypertension. Okay, controlling the hypertension is the key factor in prevention of any stroke. The other causes of hemorrhagic strokes are trauma or substance abuse, especially smoking, or could be a rupture of any aneurysms inside the brain. Secondly, ischemic stroke, it could be because of atherosclerosis or thromboembolism, right? So, the results of the stroke are basically there could be a neurological deficits or loss of functions in the affected brain regions. Now, once we understand the pathogenesis, let us discuss about the clinical manifestations. Okay, so because of the underlying pathology, it can lead to sensory and motor deficits. Okay, so it can lead to various motor deficits like muscle weakness or paralysis, or the blurred vision, changes in the eye movement, visual disturbances, sudden or severe headache, altered mental status or confusions, right? Dizziness, nausea. Sometimes the patients may present with symptoms like seizures also, or impaired speech or difficulty or trouble in speaking, or we call it as a slurred speech, right? Or hearing difficulties, or sometimes they may have the cognitive deficits like memory problems, poor concentrations, right? So these are the most common clinical manifestations of any stroke. Now, the diagnosis, as I said, so we should be very prompt in understanding the clinical signs and symptoms of the stroke, right? Then neurological and cardiovascular examination is important, but always remember non-contrast CT is always the first choice due to its low cost, speed and the availability. Although MRI offers the higher sensitivity for detection of the infarcts, but CT is always done first. Now, when we discuss about the treatment, as I said, control of hypertension, maybe by lifestyle modifications or by prescribing the proper medications. Lifestyle changes like the diet modification, exercise, smoking cessation or stress reduction protocols are mandatory in prevention of the stroke. Again, for the prevention of the stroke, these patients are put on use of anticoagulants or antiplatelet medications. So, for management of the acute stroke, the patients are put on the medications to reduce the bleeding or thromboembolic occlusion, reducing the brain edema, and sometimes they are put on anticonvulsants to prevent the seizures. And if the ischemic stroke is confirmed, then thrombolysis is done with intravenous tissue plasminogen activator, or sometimes the surgical interventions are carried out. Now, what are the oral health considerations? What is our role? First, because of the muscle paralysis, your facial and the masticatory muscles may get affected, and that can affect the chewing or the facial expressions, right? Then because of the sensory deficit, like loss of taste or touch, or reduced gag reflex or dysphagia, that can lead to poor nutrition or weight loss. There is always a risk of choking or gagging, and because of the diminished motor function of the masticatory or the facial muscles, limited hand and mouth coordination, all these things can affect the oral hygiene, and that can increase the risk of developing dental caries and periodontal diseases. So hence, what is advised here is a good oral hygiene and a frequent recall visits for maintaining the good oral hygiene is required. Now, when it comes to the dental management, so first thing is prevention of the stroke, right? So regular blood pressure monitoring is very essential. Secondly, in case on the dental chair, So when we identify certain clinical manifestations like slurred speech, confusion, right? So early referral becomes mandatory, and treatment of the high blood pressure can also reduce the risks for developing the stroke. Now, patients who are already having the history of transient ischemic attack or stroke, there are high chances or high it always increases the risk for developing the future strokes. So, and highest risk of the second stroke arises within the first 90 days, that is the first 3 months after the initial event. Now, what is the dental treatment? How to manage the patients who are already diagnosed with a stroke? So, here invasive dental procedures, if we need to carry out, we have to consider the medical monitoring and always use stress reduction protocols for the frequent or during the dental visits. Now, the most important here is we should be aware about the medications which these patients are on and the possible side effects of the medication. The most commonly prescribed medications for these patients are the antiplatelet or anticoagulant drugs, right? So, these patients could be on aspirin or low molecular weight heparins or warfarin. So, for routine dental procedures, we don't have to change any medications, but physician's consultation is always required. And whenever the patients are on warfarin, it is important to consider the INR ratio, right? So, it should be, if it is less than equal to 3.5, then the minor oral surgical procedures can be considered. Epinephrine, yes, we need to avoid as it increases, it can be used judiciously, but there is always a risk of increasing the blood pressure, right, and the heart rate. So, we need to be little careful when we are using epinephrine containing local anesthetics. NSAIDs, yes, it may increase the risk of bleeding, okay. So, and certain antibiotics like metronidazole, erythromycins, tetracyclines, they can alter the warfarin levels. So, we have to be careful when we are prescribing NSAIDs for these patients. And the most important is whenever any dental procedure is being considered, the stress reduction protocol is very crucial. So, that can prevent the next episode of stroke in these patients. Okay. So, to revise, it is very important to take a good medical history of the patients and consider the medications which these patients are on. Okay. So, now next coming to multiple sclerosis. Okay. So, what is multiple sclerosis? Multiple sclerosis is characterized by multiple areas of central nervous system white matter inflammation, and there is demyelination and gliosis. Gliosis is nothing but scarring, right? So, now what is this myelin? Myelin, why it is important? Myelin is very essential for rapid propagation of the nerve impulses, okay. So, in multiple sclerosis, what happens? That is due to some reason this myelin is destroyed, okay. So, there is demyelination which happens, and because of which there is slowing or complete blockage of the impulse conduction, fine, and because of which there is abnormal muscular and the neurological signs and symptoms. Muscular signs and symptoms like weakness or spasticity of the muscles which is seen, and neurological signs and symptoms like the most important is the vision problems may be observed, right. So, generally it is seen in between the age group of 20 to 45 years, and it is very common among the females. Now, if you see the etiology, the exact cause of multiple sclerosis is not known, but they feel that, or the research says that genetic susceptibility of these individuals is found. The other things which is seen is the certain triggers which are there, they may lead to some autoimmune mechanisms which leads to demyelination. So, that theory is also proposed, and there are two infectious agents which have been implicated in multiple sclerosis, especially the Epstein-Barr virus and human herpes virus 6. Now, since we have understood the underlying etiopathogenesis, now what are the clinical manifestations of multiple sclerosis? As I said, impairment of the vision, muscular incoordination. So there could be muscle weakness or spasticity of the muscles, like stiffness, spasms of the muscles, right? Then loss of balance, that is gait disturbances. Then there could be a fatigue, loss of strength, limb weaknesses, bladder dysfunctions, right? And it may lead to cerebral dysarthria, that is your scanning speech. Diagnosis of multiple sclerosis. There is no definite diagnostic test as such to diagnose multiple sclerosis, but there are certain diagnostic criteria which are proposed based on the clinical manifestations which involves the optic nerve or a brainstem or the spinal cord. Now, let us come to the treatment of multiple sclerosis. So, treatment of multiple sclerosis is divided into three categories. One is to treat the acute attacks. So, here the treatment is basically focused on controlling the sudden relapses or exacerbations, and most often these patients are put on high doses of glucocorticoids. Okay, so almost IV corticosteroids are prescribed and the dosage is 500 to 1000 milligrams per deciliter for 5 days, right? Then secondly, the treatment is done for modifying the disease, like for example to reduce the frequency or severity of the relapses or slowing down the disease progression. So in this case, most often patients are put on long-term immunosuppressants. And thirdly, to manage the day-to-day symptoms, right? So here the patients may be put on any anticonvulsants, benzodiazepines, tricyclic antidepressants, smooth muscle relaxants, or various pain medications. Okay, so why I am stressing on this slide is, so whenever we are taking a history of the patient, or if the patient is diagnosed with multiple sclerosis, please go through the medications which these patients are on, right? Now, what are the oral health considerations, like what we as an oral physician may come across? Sometimes these patients presents with symptoms like trigeminal neuralgia, okay, so which is characterized by shock-like pain, electrical shock-like pain, which may be manifested, could be the manifestation of multiple sclerosis in up to 5% of the cases. Secondly, they may present to us with sensory neuropathy. So when there is a maxillary or mandibular branches involved of the trigeminal nerve, so they may present with burning or tingling sensation, right? Or thirdly, there could be a neuropathy involving the mental nerve. So during this time, what happens is they can present with the numbness of the lower lip or chin. Okay, sometimes the facial nerve palsy, which is affecting the orofacial region. So these are some of the orofacial symptoms which they may present with. Now, what are the considerations, that is the dental management considerations for the patients who are diagnosed with multiple sclerosis? Firstly, the elective dental treatment, if it is required, can be always avoided during the acute exacerbation phase, and major dental treatment can be postponed until and unless the patient is stable. Now, the most important thing here is the corticosteroid considerations. As I said, the patients will be on long-term immunosuppressions or long-term dosage of the corticosteroids to slow down the progression of the disease. So here, the immunosuppression risk, there are always high chances of developing the infections, the oral fungal infection, that is candidiasis or delayed healing, right? And then adrenal suppression risk because of the long-term steroid use. So here, in case if we are planning for any surgery or long procedures, always stress dose steroid supplementations may be required, and we have to consult the physicians before any major surgical procedures, right? Then other oral health support which is required to be provided for these patients are, as and when required, antifungals because of the long-term corticosteroids. Then there are certain electrical toothbrushes or long-handled brushes can be used to overcome the motor impairment in these patients. Topical fluoride for prevention of the caries. Okay, so now next move on to Alzheimer's disease. Now, what is this Alzheimer's disease? This is the most common form of dementia. Now, what is dementia? Dementia is basically defined as it is an acquired deterioration in cognitive abilities. So this which impairs the successful performance of the activities of the daily living. Okay. Now what is the cause of this Alzheimer's disease? What happens in this Alzheimer's disease? Here what happens is there are some neuritic plaques, okay, or some neurofibrillary here tangles are formed in the brain, and then this is seen along with the degeneration of the neurons and synapses. Okay, so there is a degeneration of the neurons and synapses which happens in this case. Okay, and the what is the cause of this Alzheimer's disease? Again, the exact cause is not known, but genetic susceptibility or genetic basis for the Alzheimer's disease has been proposed. Now, what are the clinical manifestations of the Alzheimer's disease? Clinically, it can be categorized into 3 phases. Like there's something called as preclinical Alzheimer's disease, mild cognitive impairment which can be seen, or dementia which is caused due to Alzheimer's disease. Okay. So now in preclinical Alzheimer's disease, it occurs before the changes in cognition and everyday activities are observed, and primarily it can be used only for the research purposes. Whereas in cognitive impairment, right, due to Alzheimer's disease, here it is characterized by very mild changes in memory or any other cognitive abilities which are there, but they are noticeable by the patient or the families, but they are not sufficient to interfere with the day-to-day activities of the patient. And lastly, in dementia, which is caused because of Alzheimer's disease, here it is characterized by the changes in 2 or more aspects of cognition and behavior which interferes with the ability to function in everyday life. Okay, so for the diagnosis, as I said, there are some biomarker assessments can be done, which are the markers for the protein deposition in the brain, or to understand the neurodegeneration, or MRI which shows the atrophy of the brain. Now what is the treatment? Here actually there is no cure for Alzheimer's disease, but again the therapy is aimed to slow down the progression of the disease. And here what happens is, here these patients are put on cholinesterase inhibitors, right? So what is this cholinesterase inhibitors? They are generally prescribed in mild to moderate cases of Alzheimer's disease, right? They are considered as a standard of care. Now what are these cholinesterase inhibitors and how do they work? They basically decrease the hydrolysis of the acetylcholine which is released from the presynaptic neuron, right? So these cholinesterase inhibitors basically they inhibit this acetylcholinesterase enzyme and thus results in stimulation of the cholinergic receptors. Okay. Sometimes these patients will be put on antidepressants to treat the underlying depression. Okay. So these are certain oral health considerations, like maybe because of the long-term medications like antidepressants and all, they are at a higher risk of developing caries, periodontal diseases, orofacial pain. So we need to treat these patients accordingly, like a preventive program, like frequent oral examination, hygiene educations can be given, right? Or modifying the toothbrushes, or complete restorative work can be carried out when the disease is in the early stages, and we may have to avoid the lengthy or the complex treatments. Now, dental management as far as it is considered, here cholinesterase inhibitors, they can lead to siluria. Okay, so siluria, that is excessive salivation in the oral cavity, which may be a challenge for us when we are considering dental management of these patients, and in case if the patients are on long-term antidepressants, that may lead to xerostomia. So we play a very important role in managing the secondary complications which are caused because of the medications like cholinesterase inhibitors or antidepressants. Okay. Now moving on to the next disorder, that is seizure disorders. So what is seizure disorder? What is a seizure? A seizure is basically a paroxysmal event due to abnormal, excessive and hypersynchronous discharges. You can see here, this is a normal neuron, and you can see here the neurons which are firing the electrical impulses in a normal person, whereas here you can see there are multiple impulses which have been fired, right? This is an epileptic patient. Okay, so there are hypersynchronous discharges from the neuronal aggregates which happens in the central nervous system, right? So, and what is an epilepsy? Epilepsy is basically a group of disorders which is characterized by recurrent seizures, right? Now, if you classify the seizure, it can be classified under three categories. There is focal involvement, generalized involvement, or there could be unknown. So, in focal or partial, here what happens is there could be or these neuronal impulses may start in only one hemisphere, right? So, whereas in generalized there could be, maybe there could be involvement in both the hemispheres. Okay, so it can lead to three types of seizures, like absence of seizures, that is your petit mal epilepsy, or tonic-clonic, which is called as grand mal epilepsy, or there is third, it is called as, like, there could be an absence or atonic or myoclonic seizures, right? And third one is when you cannot identify the exact location of the changes, it is classified as unknown. Okay. Now, if you see the clinical manifestations here, in simple or the partial seizures, there are localized neuronal discharges which are seen. Okay. So, there may not be any loss of consciousness, but the symptoms like clonic jerks, or which is called as Jacksonian march, the jerks will start and slowly it will start spreading to the adjacent muscles. Whereas in complex partial seizures, what happens is there could be, it is very common among the adults, there could be an impaired or loss of consciousness may be seen, right? And a certain feature like aura. Aura is like suddenly the patients will develop a fear, they will detach from the surroundings. Okay, there could be a confusion or a hallucination. So we should be very prompt in identifying these clinical features, and they are always at a risk of chewing or lip biting or any form of violent behavior. Similarly, in tonic-clonic seizures also, it may be of a sudden onset. So patients may develop this aura-like symptoms, and there are two phases, that is a tonic phase where there is sudden muscle rigidity, or and then it can be followed by rhythmic jerks, right? And here also there are high chances that the patients may injure themselves, like tongue biting, lip biting, or aspirations when the dental procedure is going on. There are high chances that they may aspirate certain dental instruments or any materials. And lastly, there is something called as, there is a status epilepticus, where it is a prolonged or there are repeated attacks which are seen, and this is a cause for medical emergency. And then we should be aware about photosensitive epilepsy also, which gets triggered. All these symptoms may get triggered by flashing or flickering light patterns. So we need to be careful. So when we put on the dental chair light. Okay. Now, diagnosis of these seizures can be based on the clinical evaluations or various imaging modalities, but the most important key tool for the diagnosis is EEG, that is electroencephalogram, which detects the abnormal rhythms in a spike wave pattern, right? Now, for the treatment, what is most important for us is these patients are put on anticonvulsants medications. Okay, so now here the applied part, or what oral physicians we need to consider is like fixed prosthesis are always preferred over the removable, because there is always a chance that during these attacks or the seizures they might harm themselves, or if there are removable prostheses they might swallow or aspirate. So there are high chances, so always fixed prostheses are preferred. Then patients, since they are put on phenytoin, it may lead to gingival hyperplasia, right? And there are certain side effects which we need to consider for the patients who are on anticonvulsants drugs. Okay, so this is a very important slide. So anti-epileptic drugs, the complications which can be found because of the anti-epileptic drugs are, one is blood dyscrasias. So most of these drugs may lead to bone marrow suppression. So there are high chances of developing leukopenia or thrombocytopenia, right, or platelet dysfunction. So all these things may increase the risk of the patient for infections, delayed healing, right, or post-operative bleedings. So we need to consider the complete blood count or platelet count. Coagulation studies have to be carried out before considering any surgical treatment. Next, since carbamazepine, it is a hepatotoxic drug, so we need to monitor the liver function tests, right, in case if the seizure control is very poor. And thirdly, valproic acid. Valproic acid, we need to avoid aspirin or NSAIDs, which can further increase the risk for bleeding. Next, when the patients are on phenytoin, especially the phenytoin, it may increase the risk for developing gingival hyperplasia. Okay, so this phenytoin which is there, it impairs the collagen degradation, leading to drug-induced fibrous gingival enlargement. This gingival enlargement is exacerbated by underlying inflammation. So what is important? It is frequent oral prophylaxis or frequent scaling, and having a good oral hygiene plays a very important role in these patients to prevent the gingival enlargement. Then other oral effects of anti-epileptic drugs are xerostomia, because of the long-term use of these medications, and that can increase the risk of developing caries or opportunistic infections like oral candidiasis. So in general, the preventive care like topical fluorides, antifungal agents play a very important role. Okay, now next move on to Parkinson's disease. Now what is Parkinson's disease? It is basically a chronic, progressive, it is a neurodegenerative disorder. Okay, this is a neurodegenerative disorder which is characterized by 4 cardinal motor symptoms. Okay, there are 4 cardinal motor symptoms, that is resting tremor, rigidity, gait disturbances and bradykinesia. So these are the 4 cardinal symptoms of Parkinson's disease. Okay, so here etiopathogenesis, here what happens is there is dopamine depletion which occurs because of the degeneration of the dopaminergic neurons. So I said it is a degenerative disorder. So here what happens is there is a depletion of the dopamine, which further leads to motor symptoms and non-motor symptoms, right? Motor symptoms are, you can see here, tremors or rigidity will be there, right, or bradykinesia or postural instability. So you can very well see in this picture. Okay, so bradykinesia is basically, it is slowness of the movement, and postural instability, or there could be rigidity or stiffness of the limbs. So these are the 4 cardinal symptoms of Parkinson's disease, right? Currently there are no laboratory tests which are specific for idiopathic Parkinson's disease. Now, as far as treatment is concerned, along with the physical therapy, speech therapy, so these patients are put on dopamine replacement therapy. Okay, the name of the drug which is given is levodopa or any dopamine agonists, right? So as I said, there is dopaminergic neurological degeneration which is seen. There is decrease in the dopamine level. So these patients are put on dopamine replacement therapy, right? So oral health considerations we need to use because of the postural instability. It's always better to use the upright position because there is a risk for dysphagia or altered gag reflex and all, right? So maintaining a dry field when you are doing any procedures becomes mandatory. And since these patients are because of the long-term medications, so there could be secondary complications because of xerostomia, right? So dental management of this patient includes monitoring the vital signs whenever we are doing any dental procedures, because levodopa and dopamine agonists, right, they can cause orthostatic hypotension or hypertension. So it's always mandatory to check the blood pressure and ensure the safe positioning or the repositioning in the dental chair, right? And other side effects, or managing the other side effects, as I already mentioned, because of xerostomia there could be increase in the caries. So for that we can use fluorides, salivary substitutes can be used, and hygiene reinforcement becomes very important. And again, there are a lot of challenges because of facial dyskinesia. So it becomes very difficult to fabricate any prosthesis because of the design of the prosthesis we may have to change, and the stability of the prosthesis also becomes a challenging management for managing this patient. Then next, let us move on to myasthenia gravis. So what is myasthenia gravis? It is a chronic neuromuscular disease which is caused by autoimmune destruction of the skeletal neuromuscular junction. Okay, so there is an autoimmune destruction of the skeletal neuromuscular junction area, and that results in impaired neurotransmission and the muscle weakness. Okay, so here neurotransmission get affected and leading to muscle weakness. Okay, you see here, as I said, it is an autoimmune disease. This is a normal neuromuscular junction, and this is the altered neuromuscular junction which is seen in myasthenia gravis. Here what happens is autoantibodies are produced on the postsynaptic membrane, right? And these autoantibodies which are there, they block or they destroy the acetylcholine receptors, and that is why the neurotransmission will get affected, and that leads to muscle weakness. So we can see here the normal muscle contraction, and you can see here what happens in myasthenia gravis, right? Okay, so because of the altered neuromuscular junction and the activities, so you will find the various clinical manifestations like muscle weakness, then fatigue, then ptosis or droopy eyelids, blurred or double vision could be seen, diplopia we say, then oropharyngeal or facial masticatory muscle weakness, it is a very common, then limited or facial expressions. And because of the facial muscle weakness, it leads to dysphagia, asymmetry or dysarthria. What is the treatment of this? It is symptomatic treatment. So here what happens is either they give anticholinesterase drugs. Okay, so these anticholinesterase drugs which are there, what they do is they increase the acetylcholine at the neuromuscular junction. So that the main idea is to improve the muscle strength. Right, so it increases the acetylcholine at the neuromuscular junction, right. Sometimes a surgical procedure like removal of the thymus is done in case if anti-acetylcholine receptor, the markers like it is positive for myasthenia gravis with thymoma, right, or these patients are put on long-term immunosuppressive therapy, that is it could be corticosteroids or non-corticosteroid immunosuppressants. Okay, so now oral health considerations. Yes, there is always a high risk for aspiration whenever we are considering any dental procedures. So use of rubber dam or high volume suction is preferred, right. Then risks of developing any respiratory crisis could be there, right, or the drug precautions, we need to avoid certain drugs which can impair the neuromuscular junctions like tranquilizers or barbiturates and all, right. And the most important here is, since these patients are put on long-term immunosuppressive agents or corticosteroids, so always there is a risk of immunosuppression leading to oral candidiasis, delayed healing and adrenal suppression. So this point we have already discussed. So the same precautions needs to be taken in patients with the myasthenia gravis who are put on long-term corticosteroids. Lastly, we come to let us discuss about the Bell's palsy. So what is Bell's palsy? Bell's palsy is basically, it is an idiopathic acute peripheral nerve palsy which involves the facial nerve which supplies all the muscles of mastication or facial expression, muscles of facial expression. So this is recognized as a unilateral paralysis of the facial nerve, usually because of the inflammatory reaction, okay, which affects the facial nerve. So what happens? What is the pathophysiology? Any form of trigger, So it could be an viral infection. Okay, so when you say it's a viral infection, the most common viruses which have been identified are herpes simplex virus, and less commonly the varicella zoster virus also, or a trigger in the form of any autoimmune or idiopathic inflammatory reactions. Okay, so because of this trigger, what happens is there is an inflammation of the facial nerve. So the facial nerve becomes inflamed and it becomes edematous within the narrow canal. Okay, so because of that there is a swelling. Because of the inflammation and the swelling, it causes compression of the nerve, right? So because of the compression of the nerve, what happens is there is ischemia and demyelination. Okay, so this compression will compromise the blood supply, that is ischemia, and then it leads to segmental demyelination. So because of which it further leads to blockage of the conduction. Okay, so that is disrupted nerve conduction, and that leads to your lower motor neuron facial palsy. Okay, so because of the lower motor neuron facial palsy, it results in paralysis of all the muscles of the facial expressions of the affected side. Sometimes what happens is the other nerves could be involved, like for example there could be involvement which are there along the path of the nerve, that is your chorda tympanic nerve, or there could be greater petrosal nerve could be involved, or stapedius nerve. So in case if chorda tympanic nerve is involved, there could be taste loss or reduced salivation could be seen, or in case if there is a greater petrosal nerve is involved, there could be reduced lacrimation, or stapedius nerve if it is involved, it can lead to loss of stapedius reflex. Now, what are the clinical manifestations? Early sign, there could be a slight pain around the ear, and there is abrupt paralysis of the muscles of the affected side. You can see here paralysis of the muscles. So you can remember this mnemonic as a Bell's P. So wherein blinking reflex, that is eye changes, that is inability to close the eyelid, right? Or because of this there could be risk of corneal ulceration due to impaired blinking. Then earache, lacrimation gets either deficient or excess. Then loss of taste, mouth changes could be drooping of the corner of the mouth, drooling could be seen, masticatory effect like weakness of the masseter muscles, the food gets retained in the buccal or the labial fold, loss of forehead creases, and asymmetric appearance is seen. And in case if there is a chorda tympanic nerve is involved, loss of taste on the anterior 2/3 of the tongue with reduced salivary secretion. So as far as the treatment of Bell's palsy is concerned, systemic corticosteroids are prescribed, and most of the time, like in case of viral etiology is suspected, then anti-herpetic drugs like acyclovir is prescribed, and then protecting the eye with the drops or the ointment, physiotherapy, and sometimes the patients may require plastic surgery, that is facial plastic surgery. Now, what are the oral health considerations? So it is very important for us to identify the Bell's palsy from the other causes of the facial nerve palsy, and then systemic drugs, like since these patients are on long-term corticosteroids, again the same protocol we need to follow, like they'll be more prone for any fungal infections, or whenever you are considering any surgical procedures, it's very important to remember about or consider the adrenal crisis, right? And then for the dental drugs or to support for the complications of these long-term corticosteroids, we may have to prescribe the fluorides or good oral hygiene with chlorhexidine mouthwash, salivary substitutes, right? And we have to defer the elective care in the acute phases, and modification of the dental procedures, as I already said, if the patients are already on steroids, protection of the eye, and supporting the oral function, right? So now to summarize, as I already said, the neuromuscular disorders, it's actually a broad term. It consists of lot of disorders, but the ones which I have discussed, they are the most common ones which our oral physicians may encounter in their day-to-day dental practice. Okay, so understanding these neuromuscular diseases is very important because the oral findings which are there, they may often reflect the underlying systemic diseases, right? Secondly, these patients are on long-term medications that can lead to certain side effects, like as we discussed, the gingival overgrowth, which is that is hypertrophy, which is seen in patients with seizures. Then most of the time they will be on antidepressants and all for a longer period of time, that can lead to xerostomia. Patients may be on corticosteroids. There are a lot of complications which may arise because of the long-term corticosteroids. So we have to be, we need to take the medical history or the medications history in detail. Then thirdly, controlling the risk factors, like controlling the hypertension or the patients, the smoking, the lifestyle modifications which may trigger the certain neuromuscular diseases like CVA or stroke. Then most of these patients are on antiplatelet, anticoagulant therapy, corticosteroids, immunosuppressants. So these medications require a special precautions before any surgical or invasive dental procedures, and hence a good case history and an individualized treatment planning, it minimizes the risk, that ensures a very safe dental care and improves oral health outcomes. Okay. So you can refer these books, especially Burkitt's Oral Medicine 10th edition. Thank you very much.